Hello, Dr. Gary Swift. Thank you so much for talking with me today.
You're welcome, Christy.
Gary, what is considered normal for fertility and when should couples start to be concerned?
Christy, human beings are not very fertile in the animal kingdom. Most couples think that they have sex once at the right time, a baby should be the result. But the realities are that the chance of a healthy young couple under the age of 35 with nothing wrong, having sex at the right time in a cycle, chance of getting pregnant is only 22%. So it's very low. So what couples should expect is that it can take a healthy couple up to 12 months to conceive. Now, most will conceive in the first few months, but we don't consider it abnormal until 12 months has occurred. Now, the proviso there being, as I said, they're healthy couples. There's not painful irregular periods or other potential medical conditions, because that would change that advice. Couples older than 35, we would say that evaluation needs to probably be brought forward to 6 months, just because time's sort of starting to enter into the equation when we're looking at fertility. So normal fertility does decline with age, and with women, realistically, we start to see a noticeable decline from 35 onwards. So that's where we start taking things seriously and doing things a little bit more quickly.
What are the main factors that can affect fertility in both males and females?
Well, there's a whole host of sort of causes of subfertility, and in fact there's still a group where we can't find anything wrong, and that accounts for about 15% of couples. But the diseases and disorders that we can identify, in males it's relatively sort of straightforward. Men who've had undescended testicles, operations or injuries to trauma to their testicles or scrotum can subsequently have reduced sperm counts. Men in some sort of industries or with toxic chemical exposure, and some medications can actually affect sperm production and function. So with men, the range of conditions, as I said, is fairly narrow in the big scheme of things. The biggest group though is unexplained, and the testicles behave like any organ in the body. If something goes wrong, they don't work properly. Unfortunately, you can't just look at him and say he looks all right, therefore his sperm's going to be good, because there's not a good correlation with how fit or healthy someone is. The things that sort of obviously can significantly impact that are easily changed: cigarette smoking has a negative effect, excessive alcohol consumption has a negative effect, marijuana and recreational drugs can have a negative effect on sperm quality, quantity and motility. And things like anabolic steroids, which suppress sperm production, are obviously the easy reversible things. So because men are a little bit easier, I've gone through them first. Women are always more complex, and there are more complexities to the processes of ovulation, tubal transport, fertility and implantation. So we tend to think that the common things we see with women, and the things that affect about 10% of women in their reproductive years, are both endometriosis, which is a disease where the endometrium grows outside the uterus, causes scarring and distortion of the pelvic anatomy, painful periods, painful intercourse, and a direct effect on fertility. And another condition called polycystic ovaries, which affects 8 to 10% of women. It's an inherited condition where eggs aren't always released regularly, cycles are often long and irregular. Some women may only have 1 or 2 periods a year, and therefore their chance of getting pregnant obviously is reduced because of that. There are some women who have polycystic ovaries have regular cycles, some are overweight, some have some masculinizing features, excessive hair growth or acne, so they're sort of pointers to the condition. But they're probably the two commonest things. The other things, that any infection in the pelvis, and particularly chlamydia or gonorrhea or germs that can actually damage the tubes inside, can alter tubal function and cause obstruction. Because mechanically, couples still need 3 things to fall pregnant. They need good sperm at the right place at the right time, they need normal pelvic anatomy, and they need regular ovulation. So the conditions that interfere with regular ovulation or tubal transport, so the conditions, as I said, infections, inflammation, surgical problems which obstruct tubes that are removed, obviously have a direct effect. Most ovulation defects are related to polycystic ovaries, but some are just due to either reduced egg supply, early menopause sometimes factor in, and some women seem to have normal ovaries, but just because of other hormonal effects in the body, either related to thyroid gland or pituitary gland, they just don't release their eggs very often. There's a whole list of rarer conditions, which are probably beyond what a brief chat can go into, but there are lots of other endocrine conditions where we think of where there's excessive or deficient hormones from multiple endocrine systems, and that's part of how we look into couples.
So Gary, what can couples expect from their first fertility consultation?
So probably the first hurdle for couples coming to a fertility consultation is to realise that we're not branding them with infertility. We're actually just accepting that a pregnancy hasn't occurred when it possibly should have and looking for causes. So the first thing that I sort of say is it's not admitting you're infertile by coming to a consultation. The important thing from my perspective is to start taking a detailed history from both partners. And obviously in a heterosexual couple, it's important to take a history, particularly from the women, when periods started, what the periods were like in their teen years, whether painful or heavy periods have occurred, whether there's been any episodes that might suggest infection inside which might damage the tubes, whether the periods are regular, whether there are signs of ovulation. So a lot of women will notice mucus changes mid-cycle, which corresponds to the hormone peak. Some women are aware, they have some discomfort in their pelvis when they ovulate. Some women have no idea what's going on, so it's not always a consistent thing. Some couples will have done testing already, so there are tests available commercially. We can pee on a stick to see when what's called your LH surge that precedes ovulation occurs. There are some tests that rely on salivary hormonal changes, and some women do their body temperature chart, which they do every morning before they get out of bed. So we need to know what testing's been done, what assessment's been done, and whether there's anything in childhood or teen years or things that might sort of point to a cause. And then, of course, a detailed clinical examinations are important. It's important to know that the uterus is actually present. There's a small number of women who are born without a uterus, but to make sure it's normal in shape and position, to make sure there's not fibroids or other tumours or lesions distorting it, to make sure there's not scarring or distortion in the pelvis. We need to look at the ovaries to see whether they have this polycystic appearance, where they're enlarged with a little sort of ringlet of follicles around the edges. We need to make sure that there's not, as I said, pain towards the ovaries or in the pouch of Douglas that would signify endometriosis. We can't usually see the fallopian tubes unless they were blocked and full of fluid, in what's called a hydrosalpinx. So you can see those in ultrasounds. So when we can't see tubes, we can't say they're normal, but when we can see them, we can say that's abnormal. We tend to take pap smears if they're due. We tend to take bacteriology swabs, so swabs for sort of germs that might be inside which may not have symptoms, and as well as sort of a general clinical examination, which may include the cardiorespiratory system, abdomen, particularly if there are other features of thyroid disease or other endocrine disease. And that's the initial sort of evaluation. With men, the mainstay of male evaluation is still the semen analysis. But certainly if there's any abnormalities in the scrotum, any swollen veins, any lumps or bumps or enlargements or failure of descent or previous surgery, or any distortions with erectile function or ejaculation, then the examination of both the penis and scrotum is important as well, to make sure there's not a physical impediment to satisfactory intercourse. So that normal consultation, going through all those sort of issues, looking for flags that says this might be the explanation, is usually followed by a series of investigations.
So Gary, what testing is required?
Well, although we can assess things clinically, we still need to do blood tests to look at hormonal levels, hormonal profiles. We can suspect ovulations occurring, but we still sometimes need to do what's called day 21 progesterone levels to make sure that the right hormonal pattern is occurring with an ovulatory cycle. We often, with women, will do hormone levels at the beginning of the month. So the first day of the menstrual period is always day 1 of the cycle. So on day 2 or 3, we'll take a blood test to look what the baseline hormones are doing. We can also do a blood test now that tells us about ovarian reserve, a test called an anti-Müllerian hormone, and we tend to use that quite frequently in women to make sure that their ovarian reserve is actually normal. We also do the normal antenatal screen to make sure sort of immunisations for rubella, chickenpox aren't necessary. We also do infectious screening for hepatitis and HIV, syphilis and other conditions which may affect both fertility and pregnancy. It's then important to make sure that there's no disturbance in thyroid function or abnormal balance of any other endocrine glands in the body, to make sure that they're not going to impact on the actual process of ovulation. And then there's, as I said, tests again to directly see whether a woman is ovulating even if her cycle's irregular. So they all require blood tests, and blood tests at a specific time. The ultrasound, as I said, for most of us is done in the rooms at the point of consultation, but it may, if for some reason we can't do a scan, if someone's in the middle of a period or something, we might need to send them for an ultrasound. The other thing, of course, is couples that we need to evaluate those fallopian tubes. As I mentioned, we can't see them if they're normal on ultrasounds, So there are two tests that we can do to assess whether the tubes are working normal. One's a high-tech ultrasound called a HiCOSY, and the other one's an X-ray called a hysterosalpingogram. And they're both done just after a period's finished to evaluate the actual fallopian tubes, either with ultrasounds or X-rays. And those tests are indicated certainly if we think that there might be a tubal problem. Some women who then have tubal problems or other suspicions like ovarian cysts or endometriosis or other conditions which may impair fertility may need a laparoscopy, where we need to give them a general anaesthetic, put them to sleep, put a telescope through their umbilicus or their belly button, and see if there are any diseases or disorders that we can actually treat or any anatomical distortions we can rectify to restore normal fertility. With men, the mainstay, as I said, is the semen analysis, and men need to collect a specimen mostly by masturbation at home. They ejaculate and collect the specimen into a small specimen jar. We ask them to have 3 days of abstinence beforehand. Much longer than that, they look stale and don't swim very well. Less time than that, then the count might not have caught up from that ejaculation. Then they have that specimen needs to be assessed by a qualified embryology scientist to make sure the count or the concentration is above 15 million per mil, that the motility or the number of sperm swimming positively in the right direction is above 32%, and to make sure by strict morphology criteria that 4% or more of the sperm are actually put together. And that's the World Health Organization 5th percentile criteria for normal semen analysis. If men are capable of normal sperm production, other than sort of picking them up on lifestyle issues, there aren't any other tests that necessarily are going to help them. So if men have low counts, then there are other tests looking for genetic problems, looking for what's called DAS or Y chromosome deletions, looking for abnormal balance in the chromosomes on blood tests, and looking for abnormal hormone profiles of testosterone production and other glandular function. So most male testing is on a secondary level if the semen analysis is abnormal, whereas if women, we tend to do a blanket test in the beginning. If couples then go on to look like they will need IVF, and some couples you can make that decision at the first consultation because there's a major problem, they will need that high level genetic testing fairly early on to make sure there's not a rearrangement of chromosomes. Because there are people who carry an abnormality which affects their sperm and eggs, but they may not function any differently to any of the rest of us, and they're called translocations or abnormalities in the genetic makeup. And they are tested. We can test for those now. Same way we can test for cystic fibrosis genes and other genetic things which affect otherwise healthy people, but make reproduction less successful.
What are the treatment options available for couples who are experiencing problems with fertility?
The treatment options directly relate to the underlying cause, obviously, of fertility. If there's a major problem, and particularly if there's a major problem on the male side of the equation, so that the count's very low, motility's poor, or the abnormal forms are elevated, or men have had vasectomies or other issues, then couples often have to go straight to IVF technologies just for the mere fact that we need to actually get the eggs and put the sperm eggs together. For women, if everything's normal and they're not ovulating regularly, they may need just ovulation induction protocols, and that can be as simple as a tablet for 5 days at the beginning of a cycle. It may, if the tablets don't work, the tablets are called clomiphene, and they have various trade names and brands. If they don't work, then sometimes we need to use FSH injections. FSH, or follicle stimulating hormone, is a hormone made by the pituitary gland, and that's what makes the ovaries release eggs every month. And women get all their eggs before they're born, but they sit in a dormant stage in the ovary, and every month there's a group of egg follicles who are vulnerable to stimulation, and if they get an FSH signal at the right time, those eggs will go into the growth phase and be potentially available to release. Usually only one egg releases, and that's the fundamental basis of a menstrual cycle. However, sometimes we need to encourage that to happen, and sometimes when we use high level techniques such as IVF, we actually want a whole batch to grow, so we want more than one to grow. Most couples, as I said, with minor male factor, ovulation problems but normal anatomy, may need ovulation induction, and whether or not we time that with timed intrauterine insemination, where we actually track the hormonal pattern of the month, work out exactly when the egg's released, then get a fresh specimen of semen from the male, spin it down in a centrifuge and put a concentrated specimen up inside the uterus in a procedure very similar to a pap smear, but with a very tiny little catheter that goes inside. That tends to have a 10 to 15% success rate, so less than natural fertility, about half, for a lot of couples. Tends to decline with age, as age comes in, and tends to decline in success rates with as period of infertility is longer and as age is longer. So that when couples are older, it's less successful. There are, as I said, couples who need IVF, and IVF in this day and age is an amazingly successful procedure for a lot of couples. In days gone by, it had a very poor success rate, but now that we've been doing it for long enough and technological advances are there, we can often help couples who otherwise wouldn't have children to have babies. Male factor accounts for 30 to 40% of couples. As I said, sometimes if there's not enough sperm, we've actually got to get the eggs from the women and put one sperm into each egg. With women, we sometimes find that there's a group of couples who we can't find anything wrong, but we try different steps, and as we get more complicated, if pregnancies don't result, then ultimately we've actually got to get the eggs out and assess them. Because although we can assess sperm from men very easily, we can't assess eggs very easily. So the only way we ever get to look at eggs is an IVF cycle, and that's when we basically either got to turn off the normal hormones that are driving the ovaries, or overwhelm them so that the ovaries make lots of eggs. Ideally we aim for a dozen, and that often requires daily injections of this FSH. And there's two brands on the market, one called Puragon, another called Gonal-F, and they come in little pen systems, so they're easy to administer. And usually an average of about 10 injections will make a whole group of follicles grow to maturity, and we track the hormone levels and the growth of those follicles on an ultrasound, and when they're ripe or ready, we give a triggering injection which mimics what the body would normally do with what's called an LH surge from the pituitary gland, and then we specifically time, usually about 37 and a half hours after that triggering injection, and put the women to sleep, and with a little internal ultrasound probe and a little needle, we actually take the eggs out of each of the follicles that result. And those eggs then are available in the lab to either put with sperm, so that the strongest sperm fertilises them, or, as I said, sometimes if there's a male factor, we've actually got to pick one sperm for each egg and put them in. And then what happens with IVF after then is 24 hours later we check for fertilisation. Ideally we can grow them for up to 5 days in the laboratory, and they go through a series of stages till they reach what's called a blastocyst. Now, blastocyst is the little stage where it actually hatches out of its shell and wants to implant or grow in the wall of the uterus. And that's the stage where we would put that embryo back up inside the woman's uterus. Again, a procedure like a pap smear, and hopefully give that couple the best chance of pregnancy. Now, in this day and age, what to expect with success rates, again, they depend on the underlying cause of infertility, but in the best groups, women under 35 who have simple mechanical blockages, we can expect pregnancy rates of 45% per transfer, and then sometimes as high as sort of 65 or 70% if you look at cumulative pregnancy rates from a batch of embryos that are being created. We freeze the good ones that we don't use so they can be used in future cycles, and the success rates now from frozen embryos are actually approaching that from fresh, and it gives couples potentially the chance for more than one baby out of a batch of eggs, but also gives them a better chance of getting a successful pregnancy. Obviously age, other disease processes, if we don't get good eggs or embryos, will actually impact and reduce those success rates ultimately. And the other thing probably to mention, in this day and age we get more women who are single, women who are in same-sex relationships, and sort of couples with various scenarios where some men might not have sperm at all and they use donors. So there's a lot of other groups where we actually are using various levels of technology to suit the particular situation. And sometimes that's using donor sperm, using timed inseminations, or sometimes couples using IVF technologies, as I said, again, in proportion to all the factors that are relevant. And we try and help everybody regardless to try and achieve their dream of having babies. And we use the technology as appropriately as we can to help that.